Okay, this is chapter 10, recording 6, talking about utilizing a bag valve mask to actually ventilate your patient. Whenever it's possible, you want to try and use two people. Well, utilizing a bag valve mask isn't necessarily difficult. It does require some technique to do it efficiently. And myself, I have teeny tiny hands and not super long arms. So when I try to ventilate a patient by myself using a bag valve mask, yes, I can do it, but I look somewhat like a contortionist trying to use both hands to hold the mask on and then twist around so that I can utilize my leg to an elbow to collapse the bag. It's just not a pretty sight. So, if at all possible, try and use two people. One person will maintain the mask seal using the EC clamp method, and you were shown that during CPR, and we'll go through that during lab day more and more as well. And they're going to maintain the head tilt, chin lift, or the jaw thrust, depending on how you've opened the airway. They're going to maintain that mask over top with a good seal. Now, does it mean that there's no air leakage? No, there can be some. As long as you can get an adequate chest rise, even with the air leaking, you're golden. Not a problem. Make sure that you suction as needed. Determine if you need to have an oral or a nasal airway in to assist you. Remember, OPAs are only used when the patient is unconscious without a gag reflex. NPAs can be used in patients that are semi-conscious or unconscious that still have a gag reflex present. When you're ventilating a patient, make sure that you are allowing them time to actually exhale between ventilations. If you're ventilating at the proper rate, they should have plenty of time to go ahead and breathe out. You have to actually squeeze the bag for them to breathe. If you hold a really good mask seal over their face and don't actually squeeze the bag, even though you have oxygen flowing into that reservoir at the back, you're basically suffocating your patient. So don't just set that there and leave it there. You have to actually squeeze in order to help them out. If you're using just yourself, typically you're going to be holding the mask with one hand, squeezing with the other. Like I said, I try and make it as possible for me to use two hands to get a good mask seal and then find other ways of squeezing the bag. And you should practice that during lab. See if you can do it by yourself. See if there's different ways that you can maneuver in order for you to effectively ventilate the patient by yourself. If you're using two people, that's easy. You've got two hands that maintain the seal, and you've got another two hands to squeeze the bag. We talked about the fact that if you don't ventilate appropriately, that you can get severe gastric distension. You are going to have some air go into the stomach, irregardless of what you do. No matter how careful you are, you will have some air go down. It's just how much air that depends on whether it's going to become a problem for you and your patient. If you ventilate the patient too forcefully or too rapidly, air will go into the stomach at higher volumes. So slowing down, going at the proper rate, just delivering enough to go ahead and cause the chest to rise is going to protect that from your patient. If you get severe inflation of the stomach, aside from the fact that they are going to throw up, it can actually cause huge problems. For kids, you can actually reduce the lung volume that you have to ventilate with. So that big stomach is going to start pushing up on their diaphragm. Their diaphragm's not going to be able to move anymore. And so you're not going to get full lung expansion anymore. In order to prevent or to alleviate gastric distension, make sure that the patient's airway is appropriately positioned. If you have it positioned, you should be semi-kinking off the esophagus so that the path of least resistance, it shifts more to being the actual trachea. If their stomach appears to be distending, recheck, reposition the head, watch for rise and fall. Try to go very slow when you're ventilating that patient if you notice that they're having gastric distension, so that you don't make it worse. You want to try to still ventilate without making the problem worse. If you cannot ventilate the patient because you have so much gastric distension, you may need to end up calling ALS. We can actually throw a tube either up the nose or through the mouth that goes into the stomach, and we can pull all of that air out. If not, and you absolutely cannot ventilate them, you can't get an ALS provider there, you may have to just put pressure over the abdomen. Yes, you are going to force that air out. Yes, you are going to make them vomit. So you're going to want to position them properly once you do, but it's life over limb. If they can't breathe, they're dead. If you make them aspirate, yeah, not great for them, but at least at this point you've removed air from the stomach so that you can actually ventilate them appropriately. Manually triggered ventilation devices, also known as flow restricted or oxygen powered ventilation devices. This allows a single rescuer to use both hands to do a mask to face seal and still provide positive pressure ventilation. You typically have to have a special unit and more training to be able to do this with infants and children. We don't use it in patients with COPD or suspected spine or chest injuries. There are a couple of different types. The automatic transport ventilator or the resuscitator, it provides a peak flow rate of 100% oxygen at up to 40 milliliters or 40 liters per minute, excuse me. It has a pressure release valve, an audible alarm that sounds when you exceed that pressure valve. Typically can use it under different conditions safely. You can set all of the different variables. For most models, they have adjustments for both respiratory rate and tidal volume, and you can estimate the tidal volume so you can set it appropriately at 6 to 7 milliliters per kilogram. You want to continually reassess your patient, make sure that you're allowing for full chest recoil, so full exhalation. If that's not happening, you need to adjust your settings. Typically, we don't use a lot of these out in the field. If you do, you will receive training on it. You have to. CPAP, this is something that we do use. CPAP is continuous positive airway pressure. This is a very non-invasive way for people to have that ventilatory assistance that they need without you squeezing a bag. People diagnosed with obstructive sleep apnea tend to wear CPAP at night. And as an EMT, this is something that you guys are able to use more and more. This used to be just an ALS technique. It's no longer just ALS. You get to use it as well. So what it does is it increases pressure in the lung to open up the collapsed alveoli, and it forces more oxygen across that membrane in order to allow for better oxygenation. Also, if you have fluid within the lungs, it can force that back into the pulmonary circulation as well. This is typically given through a mask that is held over the face by a strapping system. You have to have a good seal with this. There has to be minimal air leaking in order for it to work. And so these masks tend to be huge and then very uncomfortable, and they tend to be very, very tight to the face. So there are certain times when you can't use it. Because of this pressure and everything, you can potentially cause your patient to have low blood pressure because it does cause a drop in cardiac output. So keep that in mind. Indications for use. Your patient has to be alert and able to follow commands. The patient has to display obvious signs of moderate to severe distress from a condition that's either pulmonary edema, so fluid in the lungs, or obstructive pulmonary disease, so something that's not allowing the air to get in the way that it would, so COPD, emphysema, asthma. The patient has to be breathing rapidly to the point where it's actually affecting the overall minute volume. Sometimes it's just that they're tired and they can't get going with it. The pulse oximetry should be less than 90%. If it's at least 90 or higher, then typically we can help them out in a different manner. Contraindications. If you have a patient that's not spontaneously breathing, this is not going to work whatsoever. If they have a sign or symptom of pneumothorax or chest trauma, pneumothorax is when you get a hole in your lung and you start collecting air within the pleural space, and it can start collapsing your lung. In a patient who has a tracheostomy, we don't use this. If they have active gastrointestinal bleeding or vomiting, we don't want to put this on there because chances of them filling up the mask with vomit or blood and then having that forced into the lung is way too high. If your patient is unable to follow verbal commands, we don't want to put this on them. If they're extremely claustrophobic, they probably are not going to tolerate it. And make sure that you continue to reassess your patient. Once you put this big mask on them, it's kind of hard to reassess them. So make sure that you're constantly checking them. When you apply a CPAP to them, you're going to end up using a force of centimeters of water to try and force that in there. Your range is going to be 7 to 10. And how you check that is you actually have to set it and then obstruct the mask. So typically we push it against our thigh, a hand, depends on how you can completely obstruct it, and then see where that force falls. You can't just set it and then put it on the patient's face because it's going to jump clear up. Some patients just cannot use a CPAP. They freak out. Not going to happen. So if they are like that, you guys don't have the ability to give them medications to calm them down, so you're going to have to find a different way. It does have the possibility for causing a pneumothorax because it continues to push pressure into the lungs. If they have a weak spot, you may end up popping them. This can lower a patient's blood pressure, so they do have to have a minimum blood pressure in order to use CPAPs, and that does range from service to service. Some say they have to have 100, some say they have to have 90. Just know that there is a minimum that they have to have. If they show signs of deterioration while you have that CPAP on, take it off and start positive pressure ventilating them with a BVM. There's several different special considerations for how we maintain an airway. A stoma or a trach tube is an opening in the neck. It connects the trachea directly to the skin. So the stoma is the actual hole. The tracheostomy tube is what goes in it. Patients may have other openings in the neck, kind of depends on what the operation was, but you can ventilate a patient directly through a tracheostomy tube. The attachment at the end of that tube fits right onto a BVM. It is the same size. So you can go ahead and put air into the patient's lung by using this. If the patient does have a trach, you don't have to do a head tilt chin lift or a jaw thrust in order to maintain the airway. You're underneath of the tongue, you're closer to the full airway, the lungs, so you don't have to worry about that tongue getting in the way. So you just want to go ahead and put your BVM, attach it to oxygen, attach it to the standard adapter, and then go ahead and ventilate. If they have no tube in place, but they do have a stoma, you can actually use the infant or child-sized mask with the BVM to make a good seal over the stoma. The adult-sized one just tends to be a little bit big for the situation, so dropping down to that smaller mask will make things a lot easier. You do have to seal the patient's mouth and nose to prevent air from going the wrong way and leaking out. And if you can't ventilate, you need to go ahead and try and suction that stoma. They tend to create a lot of goobers in there, so you might have to get them out before you can effectively ventilate.